This case gives us the opportunity to discuss inhibitors, specifically for patients with severe hemophilia A. Inhibitors remain the most significant complication of hemophilia therapy and are associated with increased morbidity, mortality, and resource utilization. The highest risk period for inhibitor formation is within the first 50 to 75 exposure days. Determinants which modify the risk of inhibitor include race and ethnicity, higher in Hispanics and African Americans, genetic variant, higher with large deletions or null mutations, type of factor product, higher with recombinant compared to plasma-derived factor, and presence of immune danger signals at the time of factor exposure, as well as high-intensity factor exposure. At the 2018 ASH meeting, Leisner and colleagues presented data which suggest that the combination of null factor VIII mutation and treatment with recombinant factor VIII is associated with particularly high inhibitor risk. Clinicians might consider treating patients with high risk for inhibitor based on mutation with plasma-derived factor VIII versus minimizing factor VIII exposure altogether by starting emicizumab prophylaxis. The patient in the case scenario has developed a high titer factor VIII inhibitor after 6 exposure days. The patient will require bypassing therapy for management of bleeding. Options for prophylaxis now include bypassing therapy and emicizumab. Immune tolerance induction may be recommended for inhibitor eradication. The optimal ITI strategy has not been defined. ITI may be prescribed in combination with bypassing therapy prophylaxis. Alternatively, at the 2018 ASH annual meeting, Batsuli and colleagues described their experience with ITI in combination with emicizumab. However, the recently released MASAC position statement on emicizumab supports the use of emicizumab in patients with inhibitors but has not yet endorsed its use during ITI. In my experience, I have started patients with inhibitors on emicizumab and plan to offer ITI through a clinical trial when available. I continue to see value in ITI as successful tolerance allows for treatment of breakthrough bleeding with factor VIII rather than bypassing therapy, and would potentially allow for enrollment in a gene therapy trial in the future.